lecture. So it's my honor to present Dr. Aliaa. Dr. Aliaa is a professor of endocrinology at Alexandria University. She is the head of Alexandria Thyroid Association. She is the head of this meeting, and she is going to present us about when or who should be treated for subclinical hypothyroidism. So go ahead, Dr. Aliaa.
Okay, thank you, Tamer. Okay, good evening, everybody. My point today is about the treatment of the adult with subclinical hypothyroidism. And first of all, I will show you some basic information about the subclinical hypothyroidism. As you all know, it is defined by the presence of a raised TSH with a normal circulating total or free thyroid hormones in the absence of clinical symptoms, representing a clinical silent thyroid disorders. The subclinical hypothyroidism prevalence range is between 5 and 15% in the general population, and it is more prevalent in the women, Caucasian, those over 50 years of age, and men and women with a family history of thyroid disease. Individuals with an increased risk of developing subclinical hypothyroidism are those with a goiter in the family, those with treated hyperthyroidism, with a history of postpartum thyroiditis, with a history of neck irradiation, with autoimmune disorders, and with iodine-containing antiarrhythmic agents like the amiodarone, and those with DCM, and those treated with immune response modulator as the interferon, and those with the non-thyroidal illness, and those with poor compliance on thyroxine therapy. So regarding the etiology, subclinical hypothyroidism is divided into the endogenous group, where these patients have never received thyroid medication, and the exogenous group, these patients are on medication, or their subclinical hypothyroidism result from the iatrogenic procedures, as I mentioned before, those taking medications or affected by treatment. The most common cause of endogenous subclinical hypothyroidism is autoimmune Hashimoto's thyroiditis, which is usually associated with raised level of anti-thyroid peroxidase antibody, while the inadequately treated overt hypothyroidism is the most common cause of the exogenous one. Subclinical hypothyroidism can be categorized as grade 1 when the TSH level are between the upper limit of the reference range and 9.9, and as grade 2 when the serum TSH level exceeding the 10 microunit per liter. Approximately 90% of patients with a subclinical hypothyroidism have the serum TSH level lower than 10, they are grade 1. In 60% of patients with grade 1, the TSH level can normalize within over 5 years. On the contrary, grade 2 subclinical hypothyroidism is associated with increased rates of progression to overt, especially in women and in patients with positive thyroid peroxidase antibodies. And the progression to overt is dependent on the magnitude of TSH, the anti-thyroid antibody titer elevation, and the age. Each individual has his TSH set point, which increases a little with advancing age. Both healthy individuals and those with subclinical hypothyroidism have a circadian fluctuation in the serum TSH concentration with a nadir in the early afternoon and approximately 30% higher concentration in the evening and night. To diagnose the subclinical hypothyroidism, we should repeat measurement of the TSH to establish a firm diagnosis, and measurement of serum free T4 is necessary to rule out overt hypothyroidism, and the measurement of the bioinactive isoform of TSH is better than the active isoform 1. Individuals found to have positive anti-thyroid peroxidase antibody or the thyroglobulin antibodies and or those with hypoechoic or an inhomogeneous echo pattern on the ultrasound should perform serum TSH. And now, is there any reason to treat adult subclinical hypothyroidism patients? Of course, yes. This is because subclinical hypothyroidism has been associated with adverse metabolic, cardiovascular, and the neuromuscular and cognitive effects. The second point is, in today's multimedia world, with most people having access to the internet, it seems inevitable that patients will demand treatment. And the third one is, during the last decades, the medical benefits and expectation of the clinical improvement with treatment was observed and gained increased attention. And these tables show the effect of levothyroxine on patients with subclinical hypothyroidism. And as you see that it has the levothyroxine replacement is associated with improving lipid profile in patients with dyslipidemia, and also with less cardiovascular risk and mortality in patients than 65 in patients suffering from the cardiovascular endothelial dysfunction. And regarding the infertility and the miscarriage, some studies have shown lower rate of miscarriage with levothyroxine when the TSH is more than 4. And regarding the preterm delivery and the pregnancy loss, it improved maternal and fetal outcomes in these group of patients. But we should individualize management and share decision-making. Management of the subclinical hypothyroidism should be individualized on the basis of the extent of thyroid dysfunction, the comorbid conditions, the risk factor, and the patient preference. For sharing decision, the challenges of the treatment should be kept in mind and explained to the patient. As levothyroxine replacement has a multiple challenge. The first is it has a narrow therapeutic range, causing a possibility of over-replacement and a half-life of 7 days that can cause dosing errors to have a longer effect. Also, the adherence can be a challenge. The drug needs to be taken on anti-stomach, which may be a challenge for some persons. The cost of the medication, the frequent biochemical monitoring can add to the financial burden, which may be also a challenge. So these are the indication of the levothyroxine in cases of subclinical hypothyroid patients when the TSH is more than 2 times the upper limit of the normal, progressive rising in TSH, the presence of goiter, positive thyroid peroxidase antibody, pregnancy or planning pregnancy, infertility or ovulatory dysfunction, childhood or adolescence, dyslipidemia, established cardiovascular disease or risk factor for cardiovascular disease, depression or bipolar disease, therapeutic trials for clinical symptoms of hypothyroidism, and patient preference. To treat adults subclinical hypothyroidism, we should have an evidence. The evidence are the current guidelines on the thyroid hormone replacement for the subclinical hypothyroidism. And as you see, we have 4 guidelines. The first one is the NICE guidelines. It divides the patient according to the TSH. And in case of elevation of the TSH more than 10 and the age of the patient is less than 70, the recommendation is to treat. Also, when the TSH is between the 4 and 10 and the age of the patient is less than 65 and the patient have symptoms, that they consider trial for levothyroxine therapy in this group of patients. The European Thyroid Association 2013, as Professor Salman said, they include the patient with an age less than 70 and TSH more than 10 to be treated, and in patients with TSH less than 10 to have trials. And in the American Thyroid Association 2012, they recommend that if the TSH is more than 10, the patient should be treated, and if it is less than 10, they consider treatment if the symptoms suggestive of hypothyroidism or the presence of positive antibodies to thyroid peroxidase, or there is an evidence of atherosclerotic cardiovascular disease, heart failure, or risk factor for the disease. The up-to-date 2018 also recommend the treatment if the TSH is less than 7 and the age of the patient is less than 65 if the symptoms are present. And if the TSH is more than 10 or between 7 and 10 and the age of the patient is more than 65, treatment if the symptoms are present. And if the age of the patient is less than 65, the patient should be treated. And of course, if the TSH is more than 10, the patient should be treated. But before starting treatment, the levothyroxine therapy, a repeated measurement of TSH level within 3 months is important, as transient elevation of the TSH that normalized within 3 months has been reported in 60% of the cases, and it may be due to the painless thyroiditis following withdrawal of levothyroxine during recovery from a significant non-thyroidal illness and during treatment with various drugs like the lithium and the amiodarone, all these causes that make a transient elevation of the TSH level. Also, falsely elevated TSH can be found in cases with macro TSH, which can be analyzed by precipitation with polyethylene glycol. The macro TSH was noted in about 0.8% of patients with subclinical hypothyroidism, and it is more common in clinically euthyroid individual with a TSH more than 10. How to treat? The oral levothyroxine administration daily is a treatment of choice. There is no evidence to support the use of T3 or a combined levothyroxine and lisaronine in the treatment of subclinical hypothyroidism. For patients without cardiac disease, a weight-related doses of levothyroxine should be used, which is 1.6 microgram per kilogram per day. For patients with cardiac disease, a small dose of levothyroxine should be started 25 or 50 microgram daily. The dose of levothyroxine should be increased by 25 microgram per day every 14 to 21 days until full replacement dose is reached. Then serum TSH should be rechecked 2 months after starting levothyroxine therapy, and doses adjustment may be made accordingly. The aim of the most of adults should to reach a stable serum TSH in the lower half of the reference range. That means is between 0.4 and 2.5 microunit per liter. But be careful that both patients and prescribers usually expect great alleviation of symptoms of the subclinical hypothyroidism as the fatigue, tiredness, and weight gain when treating patients. But sometimes these relief fail to occur due to some underlying causes. The first is the genetic causes, as polymorphism in deiodinases enzymes converting T4 to T3, or in thyroid hormone transporters that may influence the metabolism of thyroid hormone may exist in patients using levothyroxine. The second one is the presence of other diagnoses that make the patient symptoms. And the third one is the lifestyle factors or other life events they may affect the patient symptoms. Second, the patient with persisting symptoms of tiredness and or weight gain with normalization of the thyroid function test don't require an alternative thyroid medication. Follow-up of treated patients. Once patients with subclinical are commenced on levothyroxine treatment, the serum TSH should be monitored at least annually thereafter. And for patients untreated, if the thyroid function has normalized following an initial abnormal serum TSH, no further testing required in those who are asymptomatic, have a negative thyroid antibodies, don't have a goiter. In those who have persistent subclinical hypothyroidism, but in whom treatment is not commenced, thyroid function should be tested 6 monthly for the first 2 years and then yearly after. And now I will show you 3 cases where the doctors take the decision to treat this group of patients. A 45 years old non-smoking woman with a free thyroxine of 12.3 and TSH of 10.4 and thyroid peroxidase antibody of 600 and the total cholesterol of 6.2 and complaining of lethargy. In this group of patients, the question, would you treat these patients? Of course, yes, because this patient has a subclinical hypothyroidism with positive thyroid peroxidase antibodies with TSH more than 10 and hypercholesterolemia are all potential reasons to recommend treatment for levothyroxine. The second one is 68 years. 68 years old woman present to the outpatient clinic with weight gain, constipation, cold intolerance, and fatigue. except mild rheumatoid arthritis. She has no other comorbidities. Both her daughters have been diagnosed with thyroid diseases, the Graves' disease in one and Hashimoto's thyroiditis in the other. Her TSH was 2.3 when tested 6 years ago. The current laboratory testing show no abnormalities in the general lab, but a clearly elevated TSH of 14 with a normal free T4. Her thyroid peroxidase antibodies are positive according to the cutoff point provided by the assay. Should you treat these patients as the TSH is continuing to rise? Also, the answer is yes in these patients. Because there is a very high chances that she will develop overt hypothyroidism in the upcoming period due to the higher TSH elevation, the positive thyroid peroxidase antibody, and the female gender, and the positive family history of thyroid. The second explanation is epidemiological evidence show that a TSH more than 10 is associated with a higher risk of coronary heart disease events and mortality, especially with the age of the patient. The third case is a female patient, 61 years old, present to the outpatient clinic with fatigue and weight gain. She has no comorbidities. Her family history for thyroid disease is unknown. Both her parents died of myocardial infarction in the recent years. Laboratory testing show an LDL cholesterol of 30.2, which was 2.7 1 year ago. There are no abnormalities in the general lab, but her TSH is 8.2. With a normal free T4, her thyroid peroxidase antibodies are not measured. Should she be treated with levothyroxine if a repeated TSH remain in this high level? The answer is in these patients, first of all, we should ask for or search for another causes for her complaint, particularly if the repeated TSH increase further and the free T4 remain in the low normal range. But since her symptoms are specific for that reason, we will discuss with her that we will stop treatment if no clear improvement of the symptoms occur after 6 months. So my conclusion, decision to treat or not to treat has to be individualized. The main indication for treatment of subclinical hypothyroidism is the risk of progression to overt hypothyroidism. Little evidence to support treatment on the basis of the symptoms. In milder subclinical hypothyroidism, a wait-and-see strategy is advocated to see if normalization occurs. Withholding levothyroxine could be advocated in mild form when clinical improvement does not occur or if diagnosis is uncertain, but follow-up is recommended. And this is a schematic presentation for the how to do with a patient when you check for the TSH and you find it high with a normal free T4, you should recheck within 8 to 12 weeks. And then if the TSH normalized and the thyroid antibodies are negative, we should monitor. And if the thyroid peroxidase antibodies are positive and the TSH normalized, check for the thyroid function annually. But on the other hand, if the TSH remain elevated and the symptom of hypothyroidism are present, we consider 6 months trial of treatment with the goal of TSH less than 2.5. If the symptom improve, we should continue treatment. If the symptom do not improve, discontinue treatment. On the other hand, if the symptoms of hypothyroidism are absent and the TSH is less than 10, we divide it into two categories. Between 4.5 to 7, no treatment recommended, but we can consider 6 months trial of treatment after sharing decision making with the patient. And if it is more than 7 to 10, consider 6 months trial of treatment. If the age is less than 70 or cardiac risk factor or thyroid peroxidase antibodies are present, and if the TSH is more than 10, when the age of the patient is less than 70, treatment is recommended, especially if cardiac risk factor or thyroid peroxidase antibodies positive are present. And thank you for your attention.
Thank you, Dr. Aliaa. Thank you.